Okay, this is a short review of ankle anatomy with a focus on the ligaments. So there's a cutaway of the lateral ankle, focusing on the lateral malleolus, which is right here in the center. And then inferior to that, we have the peroneal tendons, the longus and the brevis. And you can see a succinaculum around that to keep those tendons against the calcaneus. And we kind of march up here, orient ourselves with the lateral malleoli again here. See a little higher up or superior, we can kind of see the musculature from the anterior compartment of the leg coming down into the dorsum of the foot. You can see that here, and these are the extensor digiti minimi and then extensor digitorum. Right underneath those, we see the piece, just a little peek at the trochlea, and then we see the anterior talofibular ligament running from the fibula to the talus. And then underneath the peroneal tendons, just barely, we can see a peak of the calcaneofibular ligament running from the malleolus to the calcaneus. And then we kind of see our articular surface here, and that's the subtalar joint. So we got our talus, calcaneus is down here, and there's our calcaneofibular and anterior talofibular ligaments. So here's the skin removed, much easier picture to read. So we have our lateral malleolus here, fibularis tendons, and here's the longus, which is going underneath the cuboid across to the first metatarsal, and then we have the brevis, which is attaching here to the base of the fifth metatarsal. And then we can kind of look here. Here's the extensor retinaculum, which holds those anterior compartment tendons down, and then we have the muscles coming out of the anterior compartment going to the toes. And we kind of again see the anterior talofibular ligament here, a little peek of the trochlea there, the calcaneofibular ligament here, subtalar joint here. So we can kind of see this is our lateral side of the foot and ankle. There's a close-up of those anterior talofibular ligaments and calcaneofibular ligaments with all the muscles gone now. And we can kind of see also the distal tib-fib joint. And that's right here with the anterior and a posterior ligament supporting that syndesmosis. So it's really important to remember the distal tib-fib is not a synovial joint, it's a syndesmosis, which means it doesn't move very much. And we kind of see the really good tight articulation between the trochlea and the mortise that the distal tibia and fibula form. We can kind of then look at the anterior talofibular ligament here and the calcaneofibular ligament here, and then take another peek down here at the subtalar joint. And that's what we get there. Here's another close-up. Just really kind of appreciate how exposed the surface of the articular surface of the trochlea is, but also how tightly it fits into that groove of the mortise, and that's going to relate to what kinds of injuries occur there. Here's the posterior ankle. Not much happens in the posterior ankle really in terms of injuries, but you can kind of see the configuration of the foot as it attaches to the leg here. You got the mortise of the ankle, the tibia, and then the fibula. And then you can kind of see the talocural joint, a really kind of loose capsule and ligaments in the posterior aspect, and then the subtalar joint here. So now we can take a closer look at the anterior ankle. And you really see the talocural joint well, and you can see the distal tib-fib joint with the tibia here and the anterior tibiofibular ligament extending to the lateral malleolus. And then we also see the collaterals at the ankle, so we see the anterior tibiofibular ligament here, and then the medial collateral, or we're going to call the deltoid ligament here, and then we can kind of see how tightly this fits together. So we're going to really apply this to lateral ankle sprains and understand that when you have an inversion injury, you're driving the medial side, you're opening the lateral side, and driving the medial side up into the mortise of the ankle. And so then that can lead to fractures, this kind of medial side of the talus. And then those, sometimes cartilage can break free from the compression on the surface. And then that gives you something called a loose body that floats around in the joint. And then also you can have the lateral side of the trochlea kind of bump up against the fibula and then cause a fracture. So when you have somebody with a lateral ankle sprain, you really have to be thinking about this kind of differential diagnosis of these other things that can happen besides rupture or sprain of the anterior talofibular ligament, which we see here, and or the calcaneofibular ligament, which we saw in the previous pictures. So here is a lateral ankle sprain. You can kind of see the pooling of the fluid distal to the fibula, which is really common because of the gravity-dependent position of the foot. And so, people with these kinds of sprains have a lot of swelling in the foot and ankle, and it gets better when they walk on it because of the pump that moves that fluid out of their foot. So what do we see here? So this is an x-ray, and here's the mortise of the ankle. This is medial because it's the tibia, and this is lateral. This is the fibula. We can kind of see that's that fracture of the distal fibula. And what do we see here? Here's medial and then lateral, where the arrow is. We see this kind of spot in the trochlea here of the talus that's light. That means probably there's a fracture, and that could even be a loose body that we don't quite see yet in the x-ray, but that could be floating around in the joint causing swelling when the person weight bears and tries to do different activities that we're having them do in the gym. And then here's another kind of a picture with kind of two fractures, one that actually, instead of fracturing laterally, because we have lateral and then medial, one that kind of showed a fracture here on the dome of the talus on the lateral side without damaging the fibula, and then some degradation of the bone on the medial side. So these kind of bony injuries can couple with the ligament injuries that you see in a lateral ankle sprain. So then the medial side of the ankle, we said the medial collateral ligament really is called the deltoid ligaments because it's kind of shaped like a triangle. The tip of the triangle is the medial malleolus, and then the flat or base part of the triangle here, okay, is the navicular, calcaneal, and calcaneus, which is the sustenacum tali here, and then the posterior fibers kind of attach up here on the talus. So ligament's strong enough that when it's injured, you more commonly have a fracture. And so here's what a fracture would look like. So this would be an eversion type injury, which is really not that common, but you can get these. And so this eversion injury ended up, popping off the distal medial malleolus rather than, kind of damaging the deltoid ligament. It's just a really, really strong ligament. So one more important point because we're going to use this concept clinically, is how the lateral side of the foot ligaments change in different ankle positions. So see here, what we're seeing here is a cutout with everything removed except for the tibia and fibula, and then here's the talus, and then the calcaneus, and then some of the cuneiforms and cuboid have been left. But essentially, we're trying to focus in on the effect of dorsiflexion and plantar flexion on the anterior talofibular and calcaneofibular ligaments, which you see here with ankle and neutral. So when we dorsiflex, so this is dorsiflex because this is anterior, this is calcaneus, that's posterior. Here's a subtalar joint. We can kind of see here the tension. You can compare this neutral position. There's a lot of tension now in the calcaneofibular ligament. And we can't really see it, but the anterior talofibular ligament's on lax, and we kind of capture that down here. The other thing that's important is you can kind of see the part of the talus here with the foot in neutral. Well, talus is wider in the front than the back. So when you drive the talus up into the ankle mortise, you actually lose flexibility or joint play. And so that's what we mean here by, if you have the anterior talus, it's wider in the front. So you push that up into the ankle joint and you get to this close packed position. And that's what we're seeing in this thing. We're going to use that clinically in diagnosing in some of our special tests, and also understanding mechanisms of ankle injuries. It's going to be much easier to kind of fracture the malleoli when the foot's dorsiflexed than when it's plantar flexed. So here it's plantar flexed, and we can kind of see here what's happened. Instead of the calcaneofibular ligament getting taut, it's lax. We can kind of see the anterior tibial ligament here. Now it's taut. So we know that plantar flexion and anterior drawer is the function of the ATFL, or the anterior talofibular ligament. And then the exposure of the talus is quite extreme. So the trochlea of the talus here is really exposed. It's also just the narrow part, or the skinnier part, of the posterior part of the talus is in the mortise. So essentially it's a loose packed position, so there's lots of flexibility. So it's in this position that the ankle joint can wiggle around a lot in terms of medial lateral instability. Here's another look at the trochlea of the talus in a plantar flex position and the tautness in the ATFL. You can kind of really see here. So you want to think about, plantar flexion inversion injuries. First, you're thinking about ATFL, and then if you get a lot of inversion, you could then recruit the CFL, and that's a more severe type of injury. And lastly, when some of these things go awry for a long time and they can't be fixed, this would be your kind of solution. And I would just ask you to think about, what kinds of deficits you think somebody might experience if they had a complete ankle fusion. And we'll kind of talk about this in both of our classes, right, for ankle and foot. So and some of the questions is like, what muscle function would you lose? What would gait look like? How would you do stairs? And to what extent could the foot compensate for total fusion of the ankle? So I'll leave you with that.